historically, when someone looks at the novel way to manage lymphomas, which is basically based on using genomic testing, the molecular part of the disease, we're decades behind in Latin America. And this personalized treatment has a lot to do with the way we are learning more about lymphoma biology. And a lot of that, of course, in cutaneous T-cell lymphoma, the field has evolved tremendously in recent years. Why is that important to know? Because when we look, unfortunately, to many of the biggest studies in cutaneous T-cell lymphomas, there is a paucity and lack of data on what is the race and ethnicity of the patient that are being sequenced or that their tumors being sequenced. For instance, there was a publication in 2019 in Nature Genetics. In general, in cancer, the amount of Hispanic or Latino patients being reported in the studies were around 20%. However, in non-Hodgkin lymphoma, cutaneous T-cell lymphoma is a non-Hodgkin lymphoma, there were 0 studies reporting about race and ethnicity, which means that they sequence all this patient, but they never said where is the race or ethnicity of this patient that have been sequenced. And why is that important? Because we know diseases differ by geographic places. For instance, a blood disorder called thalassemia, that's frequent in the Eastern world, like in Greece and some other countries, and it's very infrequent in the United States, unless that you are descendant from this or to have an ancestry from European ancestries. Same with sickle cell disease. It's mainly, unfortunately, affecting the African-American population. So we know there are certain blood disorders that are particular to certain ethnicities. So the same thing applies for genomics. Genomics, the genes are different. That's why I have brown eyes. That's why you have blue eyes, because our genes are programmed to do certain things. But the same thing stands for cancer. That's what, again, just an example in cancer, Ashkenazi descendants, they have more likelihood of having a BRCA mutation than we do, because that's how genomically they have evolved over time. And that's what has happened throughout the years and decades in these populations. So because of the lack of genomic data in Hispanic community, is that MD Anderson and myself developed this initiative called the ELA project, which stands for Epidemiology of Lymphomas in Latin America. So what is the ELA project? The ELA project is a project in which we prospectively enroll patients with any kind of lymphoma, and we follow those patients prospectively. We see these patients from the time of diagnosis, and we follow them at the first year every 6 months and thereafter every year. And we look at the outcomes from the disease, from the treatment, but also which other factors affect their outcome that perhaps may be or not disease related. For instance, when you present a data, or when I used to present data to big congresses, many of the criticism I got is, well, Luis, you don't have this technology in Peru. And for many, many years, there's been this stigma that because you lack resources, that's why your outcomes are worse. Well, we give a bit of a shot in this American Society of Hematology meeting in New Jersey, in New Orleans this past year, in which we show that in any kind of the world, any place in the world, if you have this disease called adult T-cell leukemia lymphoma, your outcome is worse. And we included patients from the United States, we included patients from the Caribbean, from Latin America, and from Japan. We have 2 developed countries and all the other countries and developing countries, and the outcome was absolutely detrimental and the worst in all these populations, which says that the biology of the disease plays a huge role in the outcomes of the patients as well, and that there is an unmet need to improve that. So the first fall, as I said, is to learn more about these rare diseases, to study them in a place in which they are endemic, because we cannot go and study these diseases in the US knowing that these cases may be seen better in other places. And the third one is introducing genomics and molecular studies to these ethnicities and races to understand biology better. But what about the rare lymphomas? And the important thing when you use rare is that if you want to allocate resources, you're not talking about thousands of patients. You're talking about 20, you're talking about 30 patients, a number that you can work with if you have a budget that you can accommodate them. So we partnered with the Lymphoma Research Foundation and the Leukemia Lymphoma Society to develop and expand clinical trials that are novel in our institutions to the community in Texas. So to achieve that, we actually have written a grant and have received funding to get all these innovative trials that are initiated by investigators like myself and others to the community, so that way these patients can get enrolled and we can, and I would say, our enrollment of these patients with rare diseases increases by allocating funds and getting the patients where they actually live, which is in the community. Because, getting access care, if they want to be treated in Houston, they have many times to look for hotels, transportation, caregiver support, and many times they cannot do it because all they have to live is just the monthly payments they get from their employer. And many times they even sacrifice that insurance because they have to come back and forth and they lose their job. So we're bringing these novel clinical trials and developments to the community through funds. So that's another way, for example, to one, increase diversity in clinical trials, because that's what we're doing indirectly. We're increasing diversity by enrolling patients from different ethnic backgrounds and different geographic locations. And second is hopefully being able to make cancer history, as the term we use, but also in rare lymphomas and rare diseases.